Welcome to McMaster Minds, a podcast brought to you by McMaster University's undergraduate psychiatry program. This podcast will explore psychiatry training and the path to getting there through honest conversations with residents and staff. We hope this gives you a sense about the life of a psychiatry resident and staff psychiatrist, and that it helps you make the decision about whether psychiatry, and hopefully McMaster, is right for you.
Thanks so much for joining us today, Dr. Bertrand, and welcome to our podcast. Do you mind introducing yourself to the listeners?
Thanks for having me. I'm a brand new staff psychiatrist at St. Joe's in Hamilton and a professor at McMaster. I just graduated the McMaster residency program, and I'm working in the acute inpatient setting and in the dual diagnosis clinic.
What drew you to psychiatry initially?
Okay, feels like I'm back in my medical school interviews for psychiatry. But this is a question I like because I think that psychiatry is very different from all the other specialties in that when somebody is mentally unwell, it impacts every aspect of their life, social relationships, occupational function, physical health too, whereas somebody with, for example, a thyroid condition, it might not impact anything but their physical health. So I felt that the potential impact in helping to treat people is literally life-changing. That is the primary motivator for me in psychiatry. I also find the presentations super rich, interesting. Every depression is different, every psychosis is different. And I think the level of intimacy that psychiatrists have with patients is unparalleled in other specialties, and that human connection for me was the most important part of practicing medicine. So those are some of the reasons why, and I could go on forever, but those are the primary motivators.
Thank you so much. And do you have any special interests within psychiatry?
I think that I'm somebody who tended to enjoy every rotation that I did in psychiatry, which is why my practice is pretty general. But my passions are definitely psychotic disorders. I also really enjoy the mental health law component of psychiatry, that intersection with humanities. And another area of interest for me is advocating for medical equality for our psychiatric patients who are often neglected in the medical system with respect to their physical health care.
As this is a day in the life, we were hoping to jump right in and have you tell our listeners what a typical day in the life looks like for a staff psychiatrist.
Okay, typical day in the life looks like rounds at about 8 a.m, just catching up on what's occurred in literally the past 12 to 14 hours for our patients based on nursing report, and coordinating urgent tasks for the day with allied health. And then jumping right into patient care, which could look very different on a day-to-day basis in inpatient psychiatry. It might be a day of only follow-ups. There might be several new admissions, there might be discharges. Family meetings are often a part of my day, and coordinating care with allied health does take up a significant chunk of the time. And in my case, my inpatient practice is primarily in the morning with some bleeding into the afternoons, and then in the afternoons I am at my clinic, at the dual diagnosis clinic, which is a clinic for developmental disorders paired with comorbid psychiatric conditions like psychosis or mood or anxiety. And for me, that's a few hours in the afternoon working with patients, families, community partners, and the clinicians in the clinic. And my day wraps up around 4 or 5 in terms of clinical care. And right now, as I'm new to practice, I'm seeing high volumes, and as a result, I'm documenting into the evenings. But that definitely is not required to have a rich career in psychiatry. I think many people would be done seeing patients by about 2 and choose to document after.
A couple of follow-up questions. How much call do you have to do as a staff psychiatrist, and do you have any choice on that matter?
I think that would be really institution dependent. At St. Joe's, the general rule is that full-time faculty are part of 2 call rosters, one being the Psych Emerge, and then other inpatient environments are the other rosters. And the way things tend to pan out is that there tends to be groups of psychiatrists that like call and that volunteer for more call, and as a result the call burden is actually not that high at our hospital, and if required it would be about once a month, so not too onerous, but definitely if there's an interest in that line of work, can increase the frequency as much as possible. In the first few months of being a staff, many institutions don't require you to do calls, so I actually haven't done call in the first few months, which has been a nice break. But I think this really varies depending on site, including, for example, community hospitals. In interviewing for community hospital positions leading to this position, I think on average I was told it's about once a month elsewhere as well, so I think that's pretty standard, and it's definitely one of those specialties where work-life balance can be prioritized based on that standard call frequency.
And speaking on that topic of work-life balance, how do you engage in your hobbies and interests throughout the week? And has that changed from residency to staffhood?
Good question. There definitely has been change, in all honesty, from residency to staffhood, because there's lots of new responsibilities that I'm adjusting to. My hobbies and interests primarily relate to outdoor activity and fitness, and then other interests are basic needs of spending time with loved ones. So nothing out of the ordinary, and I can definitely find time for all of that. As my documentation is improving in efficiency, I'm definitely making more time for that. For me, it's evening workouts and evening socialization, and then time in the weekend for that outdoor time that's so important for all of us.
Many people think about starting a family during residency, and I wanted to ask if you have any reflections on the choice about starting family during residency or during staffhood, and what factors you might consider as part of family planning.
That is a very personal decision, I think. I don't think there is one right way or wrong way. I can think of colleagues who chose to have families during residency, primarily because of the fact that paternity or maternity leave is owed to residents as part of PARO. Whereas as a staff, there's many positions where you won't be entitled to any paternity or maternity leave unless you have a full-time appointment as a faculty in an academic department. So that's a major driver for some people. Honestly, a major driver for some people too is the fact that people in medicine tend to be older because you spend many years in schooling, and sometimes making that decision to have children while younger is something that motivates people to have children in residency. Other factors are just there's a bit more flexibility. So if you have a full-time outpatient practice or inpatient practice as a psychiatrist, taking off that paternity or maternity leave would mean you have to find coverage, and that's not something to worry about as a resident. But on the flip side, in terms of people that chose to have families during staffhood, sometimes that's been motivated by wanting to be in a financial place that's secure enough, knowing that the salary difference is very different between resident life and staff life. People that might want to make sure that their debts are paid off enough, and other reasons like potentially wanting to relocate to be near family when they might not be near family in residency. Those are some of the factors that have come into play for people I've known, but I personally haven't made a decision around that matter through my time in residency.
Those are all really important considerations. Is there anything in your daily life in staffhood that surprised you or you weren't expecting?
Yeah, I think the biggest transition for me from resident to staff is that there's much more responsibility in terms of managing the team. including helping to direct prioritization for allied health in terms of moving our patients. I think that's something that's easy to allow the attending to take care of when you're a resident, but I think as a staff, there's this sense of responsibility towards the patient to advance their care as quickly as possible, especially because many of our patients are involuntary patients, and having their rights revoked in hospital is very consequential. And also because with the limitations of the mental health laws, sometimes it means that patients are getting better but psychiatrically, but their social needs have not yet been taken care of, and there might come a time when patients can no longer be held voluntarily as a result of psychiatric improvement, but not everything has been taken care of for them socially, which is a problem. And I think that as a staff, my role has become much more in managing and directing the totality of care rather than just the psychiatric medication and psychotherapy component of care. Because as I'm sure other people have talked about in psychiatry, the social optimization is probably one of the most important components of the care that we tend to prioritize in psychiatry.
Lastly here, how do you find the coverage for vacation and time off when you're the main physician who's taking care of patients?
Personally, I've been very supported with respect to that. I think what matters in ensuring that you do have that coverage is choosing a place of work where your colleagues are supportive. Because when you have supportive colleagues, they're willing to step up for you and you're willing to step up for them. Inpatient work is more challenging to step away from, and that's one of the reasons people do choose outpatient work, is because there's times you can simply say to patients, if there's a crisis or an emergency, go to the emergency room because I'm away for a little bit. But in inpatient psychiatry, obviously hospitalizations don't stop, so coverage is needed. And then if there's a time where someone cannot choose a place of location based on perceived support, I think it'd be important to consider whether there's any models built into the culture and the management that require the other docs step up when certain docs are away, and that grant a certain amount of vacation weeks per year, because I am aware of some institutions that do that. So yes, no problems there. And again, one of the plugs for quality of life as a psychiatrist.
We're just about coming to the end of our time together today, and we have a few more questions as we wrap things up. Do you have any advice for budding psychiatry residents who might be among our listeners today?
Budding psychiatry residents, I'm going to interpret that as medical learners interested in pursuing a career in psychiatry. My advice would be to stay true to what has motivated you to go into psychiatry and what interests you about psychiatry. And inevitably, in my experience, that is the patient-physician relationship. That's the primary motivator for almost all psychiatrists and psychiatry residents I've met. And that desire to do good on a human level. And if that remains at the forefront of your mind, I think the likelihood of matching in psychiatry and having a fulfilling career in psychiatry is very high.
And what's one thing that you wish you knew about psychiatry before you began residency?
I think there's a few things, but one is that a lot of patients won't remit or totally recover in the classical sense of what we view elsewhere in medicine, and that what we are prioritizing is quality of life. Another thing is that there is a stigma around suicide that still exists, and that we know, as per the evidence, that we cannot predict suicide. And I think being aware of that earlier and having frank discussions about that earlier with people would be a positive thing, because it is something that residents face all the time, is this threat of suicide, even if they don't directly experience a patient loss. And it really dominates quite a lot of the anxieties of residents throughout residency. And I feel really strongly that it's not our role to prevent suicide, but to treat reversible conditions and to do all we can to provide compassionate care to improve quality of life. So I think knowledge of facing that stress would have been valuable to know ahead of time. And then a final variable is that in psychiatry, in my opinion, there's a lot of angst that comes from not being able to help people because of the system we live in. So not being able to increase the allotted money through ODSP or to help people find rent that's less than $1,000 per month, or to help people have supports around them in terms of family and friends that are kind. Like there's a lot that we're limited in that is so central to mental health. And I think that knowledge of those limitations is important just for like mitigating burnout in residency, for example.
That takes us to the end of our time together. Do you have any further parting comments to share with our listener?
My final parting comment is that 5 years after residency and almost 6 months into practice, I still love going to work every day. And I think it's rare for people to actually love doing their job. And I think many psychiatrists love doing their job. And I would say pay attention to the rotations where you were not counting down the minutes till the end of the day and you actually were looking forward to going to your rotation, because that's a sign that that's a field you're meant to be in. And I'm hopeful that we continue attracting more compassionate, patient-centered medical students to psychiatry, because that is kind of the trend that we have been seeing over time with the increased popularity of psychiatry. And I think our patients are better for it. So thank you for having me.